Now, I'll tell you what we did. I hope it will be interesting for you. So, what we decided to do before anything, we decided to do a thickening. This is different than soft tissue grafting. It's part of soft tissue grafting, but soft tissue grafting is divided into two different concepts. One is thickening and augmentation, which is making it keratinized. So thickening is one, attached gingiva and fixing the lost vestibule is another one. So one is thickening, one is attached gingiva. Now, of course, keratinized is, so the first step we are doing here, we are just thickening the existing. All right? How we do it? We make basically a tunnel, leaving the papilla, making a tunnel, and we are not placing the soft tissue here, we are placing it way up there. Right? This is a ready-made soft tissue. We used mucoderm here, and it's a little bloody, but there is a tunnel here and here. So why are we, if we are placing it here, why are we making a tunnel? A tissue which is moving, and then we can place it. But in the beginning, it's full thickness, but once we are here, we are not full thickness. Here, we are not full thickness. Here, we are full thickness to be able to make sure that there is room and there is no tension on the graft and on the area. So we are sticking it in and we are suturing it. So this is the first step to thicken the soft tissue. Then we decided to slowly pull the teeth downward. Now you might say, was that soft tissue necessary? I will ask you to answer that question by just looking at the sequence of the photographs. Look at the scenario now. As we proceed further, right, you can slowly appreciate what happens with this tissue as the tooth is erupting downward or being pulled downward. What happens to that thick soft tissue? Can you see what I see or not yet? Yes, and it is coming downward, where the future area that you actually want the soft tissue to be. Okay, as the time goes by, you can watch the dates. You can see how that thick soft tissue actually is not where it was, it's where you pulled it. Can you appreciate the thickness now? It wasn't like this before. So now the soft tissue is in our favor. Why, I don't know why it's like this. Anyway, you can look like that for a while. And slowly we are cutting the occlusal surface of the teeth as it is coming down, so it will not have contact with the mandibular teeth. And now you can appreciate, you see this? This was way up in the vestibule. Now it is at the CEJ area, this white thick gingiva. Now it's a time to actually appreciate the concept of extrusion from here to that, from here to the last slide I showed you. So this was before and this one is after. Do you see? Yeah? Okay. Now it's a time that the orthodontist said, I think if I continue, the tooth is gonna come out. So you might as well get in there. Before I go there, I wanted to show you some x-rays before I'm so brave to go and extract those teeth. Yeah. So this is at the time when we place the bracket, right? You can see the amount of, we are pulling it downward. This is actually being pulled. right? Slowly, you can find, slowly the bone is coming with it as we see the level of the bone from here to here. You see how the bone is growing between the roots. Wait, I wanted to show you this. From this to this. You can see, right? Yeah. Because these roots were here. So when it's coming down, all this is healthy bone. All right, let's continue our surgical session.
Doctor, how long it takes for the ortho?
Half a millimeter a month. The orthodontist was very positive that it will take 1 millimeter a month. But till the time they put the bracket, till the time we are taking x-ray, making sure, I think it's better to say half a millimeter a month. But in the beginning, it's very slow. 8 months. That's why 8 months, half a millimeter a month gives you how much? 4 millimeter. So we got 4 millimeter. Okay. So this is the time of surgery now. Based on my periapical, I think I'm okay to take the risk. Now, my plan is what now? What is my plan? Extraction, implant placement with the bone grafting to fill the buccal bone, and maybe even soft tissue grafting. So all that is on the table, ready. As you can see, almost nothing is left from the tooth. This is very short root left because of the extraction. So what are we doing now? Why are we curing this? Yeah, because I'm not gonna immediately load, and the patient wants to go to her family, right? So I'm making something that I'll use the wire and put this hanging teeth back. So I extract, I look at the area, I see the papilla, but very thin on this side. 344, the teeth are out, and I use the DD to be sure I can give a screw retained restoration. The worst thing I want to do for this case is to give a cementable after all this. So we are very careful, but the bone is very thin, so it's not as easy as possible, but we're trying our best to make sure it's going to be a screw retained restoration. So the osteotomy is done. I connect them to make sure I can take my CBCT to see what if I can go buccally, palatally. So I take my CBCT, I'm in the right position. I don't need to change much. We are using what is the 3.5 by 11.5. At that time, this was the ideal for us. And if you can see, the location of the osteotomy is related almost to the location of the restoration, not the socket. So the implant is going in. A miracle happened. What happened? 45. I didn't expect 45. I got 45. I did the second one, 45. Now my, not the far يلعب, there is another one. It's something is saying, Suhail, you want to keep her with ortho and food and dirty, you got 45. It's like she shouldn't have 45, but she got 45. So we put the second implant. The second implant also 45. Now I'm thinking, my God, what should I do with this young lady? So I'm tempted now for immediate loading, even though it was not planned. So I put the implants deep enough. Everything is fine. Now I decided, what if I can give immediate loading out of occlusion? What if? What will, at least it will keep the memory of the soft tissue from collapsing. You with me till now? Right. So with the Megagen, today with the ETK, I don't have to worry about the smoothness, but with Megagen, this is too smooth. You have to scratch it and make it, different. Then this is how it was. Okay, where are we? I think we are back to, yeah. So at this stage, I tell the orthodontist, I don't need the wires anymore, because I think I'm gonna do something else to this young lady. All right. So now, even though we are still in the surgery room, the patient hasn't gone home, but now we go to the prosthetic phase. So luckily I took some kind of a putty. I make something from the existing root of the previous teeth. And because I don't have a papilla at that time, by the way, it's very interesting if you can say, like, if I was you remember the methods of teaching. One of them is make a model. You remember where is that make a model in the sequence of learning? One is observe, classify, compare, measure, and then make a model. That make a model is where it gives you, to tell me or tell yourself, if this was my case, at this moment, I would do this differently. So this is a time, I hope you will do it differently. There is something I didn't do properly. I was so excited with the immediate loading that I actually did not think like Thomas. I thought like Suhail. All right, so this is the provisional. I kept the position of the existing soft tissue and out of occlusion, of course. So there is no reason to connect it with the neighboring teeth, out of occlusion. And the patient was shocked that she went home on that day without wires. She's extremely thankful. Okay, so the plan that she came with, let me see if I can, examinations, implant, dental implant abutment, crown, gingiva augmentation with PRF, right? And block graft. So twice we planned to do for her a soft tissue and hard tissue. One is just to fill up the gap, and one is to do a block, mobile extraction, acrylic, and ortho extrusion. This 6 became 8. The CBCT had to be done. She wanted nitrous because she was scared, but she was okay. She didn't. So this part somehow was not really, we didn't need that because of the orthodontic part. Now, let's see the videos together quickly. Right? So this is how we did the first thickening procedure. Is we make the full thickness in the beginning just to release the soft tissue, and then we make the tunnel from the vestibule area, partial thickness. There is one more video I will show you at the end because it's a long video, probably after my colleague's presentation. It's how we did the last phase. Now this is an instrument. I suggest you buy one. It's a very handful thing. It's a 90-degree curved tweezer with 10 millimeter or 8 millimeter length. So you can grab, I hope wait, let's see if I remove it or not. You saw that in the photograph in the beginning. So you can grab whatever you want, pass it, and from the other end pull it. When you don't have this, normally you have a straight tweezer, it might it will open because you're holding it. This one is like a artery forceps, click, and it's 90 degree. So whatever you catch, you give, you can grab from the other end. What we did, we put a suture, we pushed it in, we found the suture here, we grabbed it, we pulled it, it was much easier. Otherwise, there's a chance that the head of that soft tissue will not come out here. So this is once you feel this tip, you know we are on the, because you can feel it with your finger, you know you're coming out from the other end. This is, let me increase the volume. Why there is no volume? Basically, the volume is, nobody's here, okay. The volume is, this is at the time I saw this patient and I'm consulting over WhatsApp in seconds, should I remove or not? The orthodontist wasn't there. So I'm just saying WhatsApp has made our life much easier. We send x-rays, we send photos, voice message, they reply immediately while the patient is on the chair. Generally, in most of the hospitals, there is an appointment, then there is an appointment, and then there's an appointment. It takes months for a consultation. Like, for example, in Canada, this video, which the reply came in 1 minute, is probably you're looking at 6 to 7 months for this to happen, for this small discussion to go back and forth between me and the orthodontist. I wish the volume was there, but it's not there, to show you how fast we could communicate with the orthodontist about this case. Now, if this is a good news for you or not, but I think this was the best possible position of the implant at that time. Now, the reason why this is bulky, and it was not bulky before I placed the implant, is because I didn't drill. I just made the first hole and I started using expansion. Sorry? What did you say? I don't use Versa a lot. Why? Because Versa, despite of the advantages, it also removes some bone. I prefer Hanaim. If I don't have Hanaim, I'll use Versa. But if I have Hanaim, I found I don't lose any bone. I go to slow speed, not 800, what Versa is suggesting. I go to 800 and I don't do reverse. I put it on the normal, what? Forward, and I go to 100, not 800. And I find I get slow push with that. Hanaim, yeah. And the new one, the red kit, not the black kit. When you go 100 and you don't use saline, actually whatever bone you create will be left there. With 800 and Versa and saline, generally you do get a little bit of expansion, but you lose all the bone with the washout. So I found both are useful, but I am more lenient towards not anti-clockwise and not such a sharp drills. Why I stopped using Versa, even though I have it, is I had few perforations with Versa that I didn't have with Hanaim. The second thing is, whenever I wanted to move bodily, Versa didn't move with me. With Hanaim, I can move bodily. It's something like, it's not Linderman, definitely, but it gives you little bit of freeway sideways. With Versa, wherever you start, you have to remove it, use Linderman, and then continue. All right. So this is the position of the implant. This is the second one. We had a discussion. Reem, we had a discussion yesterday. You were worried about the palatal bone. Between the bad and the worst, I will always take the bad. This is not perfect palatally, right? Yeah? What is worst? Buccally. So I chose the bad versus the worst, because the thickness of the palatal gingiva is so hard and so thick, and the periostem is so thick, that there is a good chance that I will not lose anything on the palate. I will only lose on the buccal. So this was I wanted this thickness on the buccal. All right, so the implants are placed. After 6 months of provisional, the permanent is placed. Now, what I don't want to see and I see is what? Okay, that's not my worst nightmare. My worst nightmare is loss of bone in the between inter implant area. So that I thought the bone will stay because I left the 3 millimeter, but it didn't stay. So now I think we should do something to solve that problem. So from here, we took her to this. For the photograph, it's fine, but consciously, it's not fine. So from that to this, I know I still have little room if I want to play with the gum, but this is my problem that I cannot achieve. You remember I said make a model? When I said what would you do differently? You have like a minute to express your frustration. Who wants to express his frustration? What should I have done and I didn't?
You could have placed it a little deeper.
It is 5.
Give more room to the gum too.
Okay, that's possible.
Could you augment the interdental bone by tenting vertical
Bone or soft tissue?
No, bone. I'll keep it. Talk. No, bone by tenting mini screw titanium.
Tenting mini screw.
Yeah, vertical.
Could be.
No, you didn't do soft tissue graft.
Wait.
I'm
20 minutes. I have 20 minutes of surprise in the end.
The restoration 1.5.
That's what?
The connective tissue.
What this area, yeah.
Straight.
I did not know Thomas at that time. I did not know Thomas. In my provisional, I did not know Thomas. In my final, I did not know Thomas.
I think the part is
This should be
too
straight.
close to the platform.
Even my provisional, I did not know. I thought if I keep what is there, it's going to stay there. But the best part that I should have made it concave at the time of provisional and concave at the time of final, which I didn't. So this concavity was missing in both, which was against me now. So now when I look at my result, of course it's not good. So as Dr. Nabil is asking, so what about the soft tissue? So from here, slowly it's maturing with the ceramic. These are the zirconia screw retained. That means the angulation was fine. This is the bone at the time of crown placement, which is not bad, but interdentally, it's not nice. So when we look at the CBCT, we'll talk about orthodontics. Then I will come back and show you what Nabil cannot wait to see, which is it's a 20-minute video of the soft tissue graft to see how did we try to gain more soft tissue. Probably we could get more papilla. We'll do that later. So I'll ask my colleague, Dr. Sundar, to join me and continue this presentation. Dr. Sundar is a friend and an orthodontist, and he will tell us about the theory of extrusion.
Hi, good evening. I'm Dr. Sundar. I'm a practicing orthodontist from Abu Dhabi, a close friend of Dr. Suhail. So he has made his presentation very clear as to what can be the alternative to the invasive procedures you have to improve your implant sites as good as possible for you to have the best aesthetic result as well as the function as such. So what we get to know is from theory is we need bone. We need good bone for the placement of implant, for which you're going to do your bone graft or you're going to do your soft tissue for the aesthetic aspect. But so why is bone required? As the fundamentals clearly say, is the osseointegration that is required for the bone to provide you with your primary stability. So primary stability is basically dependent upon the quality and the quantity of the bone. And so primary stability is the first one which you get after you place your implant, for which, as you rightly said in theory, what is required is the quality and the quantity of the bone matters. Stabilization through is osseointegration. The second aspect of your implant getting stabilized for you to give you the permanent restoration also relies on the quality and the quantity of the bone. So why do you need primary stability? As you rightly said, is less movement, better healing. Secondary stability is to withstand the normal forces of chewing. I'm just rushing through the theory because this is my first time and I'm only confining myself to the theory as such. So is it only for stability? No, it is also for placing the implant in place, approximating the tooth they replace. As he rightly showed that there was an issue with the aesthetic aspect when he placed the implant at the end. So our idea of placing an implant is just not placing an implant for the sake of function, but it is also to make sure that you are replacing the tooth as close as possible to the natural tooth that was missing. So when you need to place any kind of replacement, our goal is not only for the function. Of course, initially in those days when implants was basically being done, it was just confined only to your stability, that's all. They just wanted osseointegration and they were quite fine with it. But then the aesthetic aspect came. And when they had that, then you had all these issues of not having enough bone, soft tissue. So what is actually required is you have to make sure that your replacement looks as natural as possible. Of course, it cannot be ideal. For you to go as natural as possible, you have to have a required amount of bone and the right amount of soft tissue structure there. So that's the basic requirement, which is in terms of bone density and volume of bone. So what is the purpose of that? To have the adequate bone for the placement of the implant is to optimize your aesthetics in terms of theory as such. So what happens to your implant site after extraction, as was actually, if you have a tooth which you are going to extract and you're going to think in terms of getting the tooth replaced, you do have patients who come to you, they have extracted their teeth, they haven't thought of replacement for a long time, and then they walk into your office for the sake of an implant replacement. You do have changes in the implant sites. Basically, you have an atrophy that is happening because the ridges become smaller, and you also have hard and soft tissues which can get damaged because the patient had some periodontitis, endodontic infection. See, look at the ridge here. So this is how mostly I get to see cases, because many people have not come for the replacement for a very long time. This should be ideal, but that's what you get. You have a periodontal infection there, or you have an infection which has been caused because of the endodontia. Now all these situations you have to think in terms of getting the bone density and the volume right before you get to place an implant. And the procedures which you have been thinking of is basically invasive, and that was the presentation that was made by Dr. Suhail, to think in terms of alternative treatment, which is the non-invasive one, which is your orthodontic extrusion. So think in those lines. Not necessary it should be always in terms of graft, not in terms of it should be an invasive procedure, putting the patient through all that as such. Of course, time is a concern, but this is a non-invasive procedure and it is definitely going to be easy for the patient. So this is what it is. You get to think in terms of doing the bone graft there, and this is an invasive procedure, but think in terms of these kind of situations. Orthodontic extrusion, which was basically presented by Dr. Suhail, was a situation where they wanted to extrude the tooth to bring about the bone along with it. As we know in orthodontia, when the tooth moves, it moves along with the periodontium, which includes your alveolar bone, which includes your soft tissue, everything together as such. But there are situations where you can also have a situation where the tooth is moved out of the alveolar socket. It is just not moved along with the periodontium. Now that is called as rapid extrusion. So in orthodontia, there are two types of extrusion. One is orthodontic extrusion, which is done in a very, very slow manner. When you want the bone and when you want the soft tissue to move along with the tooth, it has to be slow. So you should have the patience to go through the orthodontic treatment to make sure that it is a slow process. As was rightly pointed out, he said 0.5 millimeters, but let me tell you, there is no hard and fast rule as to what should be the time frame for you to move the tooth in the vertical dimension to make sure that you get adequate bone and the soft tissue contour to help you in replacing the tooth. There is no perfect rule there. All the studies are empirical. What works in one's hand is what is presented in the papers. There is no hard and fast rule saying that no, you're supposed to move it only 0.5 millimeters, you're supposed to move only 1 millimeter, you're supposed to move only, no, there's nothing like that.
So, Dr. Sundar, can I request you to tell us, in your clinical experience, the slow ideal with the soft and hard tissue, what is in your hands, the amount per week, per month, whatever? What is your protocol in your private?
When we used to do orthodontic extrusions in our practice, we used to do this. We used to do 1 millimeter of extrusion, and then we used to give a sufficient amount of time for stabilization. Now that's we used to move it 1 millimeter, wait for 6 weeks. Sometimes I even see my patients once in 8 weeks. I wait. I make sure that there is a stabilization there, and then I activate it for another 1 millimeter. There are various ways of doing it. Of course, the conventional way was done here, where you have the braces given here. Because see, when we have situations in our clinic, a patient has come to you for the replacement of implants, or rather the replacement of lost teeth in the anterior section for the purpose of aesthetics. And many of them would not like to hear the word like, okay, go ahead, get to wear a braces for the sake of your own improvement, so that we are able to extrude the tooth, bring the bone along with it, get the soft tissue to the right contour, and then I get to remove the tooth, and then I get to replace the implants. No, I'm not saying they're not going to do it, but 50% will just get a little perturbed, because when you think in terms of the private practice line, fortunately, we are blessed with aligners now. So even aligners can be used in private practice for the sake of extrusion. Initially, it was a little difficult, but now it is possible. You need a little bit of certain attachments. With the aligners, you ask the patient to wear it and you extrude it. The advantage why I am stating aligners here is relevant to the question that was asked by Dr. Suhail, because aligners, whatever you said and done, the amount of movement that is achieved is only to the tune of 0.75 to 1 millimeter per month. And then what you can ask the patient to do is continue to wear the same aligners for about 5 to 6 months, 5 to 6 weeks before you change the aligners, because that retains the corrected position, giving it sufficient time for the stabilization to see. Why I showed you this was no way relevant to what was being done or what was the case that was shown. Orthodontic extrusion can also be done for situations where you're going to have rapid extrusion. In these kind of cases, if you want to replace this tooth, you do a root canal, and as you rightly said, you can use an elastic to bring it out. You can just put an attachment here and you can bring it out. Now in this, we are not waiting for the entire segment to move. We are not waiting for the bone to move, the soft tissue. There's nothing wrong with the bone here. There's nothing wrong with the soft tissue here. But I do not have sufficient tooth structure for me to replace it. So my idea is to move this tooth as fast as possible. Now that's called as rapid extrusion, where I do not wait for 1 millimeter every month. I just pull it as fast as I can. You have a subgingival caries which is affecting the patient. You're not able to replace it. It is irritating you. Extrude it. Rapidly extrude it. Bring it out. And then you do whatever construction you want to do there. Now these kind of situations, you can do it within 6 to 8 weeks. You can pull the tooth out. Then what you do whatever restorative work you're going to do, leave it there. Give it sufficient time so that soft tissue contour and whatever the bone which is there adapts to the new position of the new tooth. Now that's rapid extrusion. But orthodontic extrusion, for the sake of achieving that bone density and volume, for you to get the adequate amount of structure there to place your implant, you have to be slow. You have to bring about 1 millimeter of movement, wait, and you have to give, my equation would be, doc, will be 4 to 6. 1 millimeter 4 weeks, 6 weeks you wait for stabilization, 1 millimeter again and do it. You're adequately sure that you have given sufficient amount of time for bone to form and for the soft tissue to adapt to the new bone that has formed in that place. But as was rightly pointed out with the case presentation, these are not absolute alternates to your bone graft and gingival graft. These reduce the amount of invasive procedures. You might still need a soft tissue graft. You might still need a little bit of bone when you're going to place the implants, but they totally reduce the amount of invasive procedures. So this is helpful. Orthodontic extrusion to be thought as an alternative to prepare your implant site so that you get enough amount of bone for the placement of your implant should be thought of in clinical practice, which will be helpful as such. So orthodontic extrusion is nothing but controlled coronal movement of the tooth. You're bringing it down, that's all. Promotes bone and soft tissue regeneration, used to optimize implant site development. PDL tension leads to bone and gingival movement. This is just theory. What exactly happens is nothing great. When you're pulling the tooth out, the periodontal ligament is also being stretched, and when periodontal ligament is being stretched, bone is starting to form. Now, keep this in mind. What was shown today in this case was just orthodontic extrusion, but orthodontia has gone beyond that in bringing about bone movement for the sake of implant. Orthodontic extrusion is just one dimensional movement in the vertical dimension. That's what I said, it's a coronal movement. But now we are able to do many things. Angular bone loss, we are able to create bone. In situations where we find that the amount of bone that is absolutely less in certain place, suppose you have molar, you have a second premolar, and you have a canine, and you find that the amount of bone in the first premolar site is very, very less. What we have done in our case, because I didn't know about this, because next time I'm going to come with those cases and show you, we have moved the second premolar into the first premolar site. When we moved the second premolar into the first premolar site, beautifully was done. This bone was available. We replaced the second premolar. We have shifted the implant site totally. So that was possible. For the movement of the premolar into the, we took about literally about 6.5 months to 7 months.
If any periapical pathology is there and we want to do extrusion, so we have to treat that pathology.
Doctor, 99% of the time when you're thinking in terms of doing an orthodontic extrusion, please do a root canal treatment. My request is that. Prior. Because whatever theory we might speak, however great our hands might be, there's always a possibility that you cannot control the amount of vertical force that you're exerting. Right? All that is theory, right? It's all beautiful. You know, things can always go wrong. So you just plan for your worst. You just tell the patient, because that tooth anyway we are going to make sure that it is going to be extracted if it is going to be orthodontic extrusion. And in rapid extrusion, the tooth is already fractured, not vertical fracture. That's a contraindication. An horizontal fracture, get to do a root canal, bring it out. So root canal is a must whenever you are thinking in terms of extrusion, because though the amount of force that is to be exerted is only about 15 grams at the apical region, practically it's not so. We can go wrong. So get a root canal done as such. Indications is vertical bone deficiency. Vertical bone deficiency, as you might always be knowing, but now I do not know the surgical aspects that are available. Dr. Suhail will be able to tell you better the amount of grafts that are available, because when I came to know that always vertical bone grafting is always difficult compared to the bulk achievement, right? So this orthodontic extrusion is a basic advantage because it is able to bring about bone formation in the vertical dimension, which is very difficult with your invasive procedure. So whenever you have a lot of vertical bone loss, kindly think in those lines of getting an orthodontic extrusion done to improve your implant site before you get to have adequate amount of bone to go for the implant as such. Subgingival fractures, as I was showing you, thin gingival biotype, I am not going there because he beautifully showed the placement of a graft there before the extrusion was done. That was brilliant. So that is what I was talking about. When you have a thin biofilm, the gingival type there, aesthetic zone enhancement, which was also shown, and the poor rich contour, which was also shown when he had an occlusal view of the photograph there, the thickness that was almost equal to the amount of alveolar ridge that was present on the other side of the place as such. Contraindications, of course, mobile teeth. Now, the next question is I asked is, I have a patient walking into my clinic. I have to clinically evaluate the patient. I have decided that yes, this placement or this patient has to undergo extraction of the tooth and has to have an immediate implant placed. Should I think in terms of a non-invasive procedure like an orthodontic extrusion to make sure that I am able to improve the implant site? The question comes is, how do I clinically make the decision? What should be the amount of mobility that I should look for? Of course, you cannot go to a situation and do an orthodontic treatment for a patient where if you tap, the tooth is going to come out. Definitely not. But clinically, all you have is an intraoral periapical radiograph. Yes, I take a radiograph, I have a look at it, and if I find that apical 1/3, the root is attached apically 1/3, that is sufficient. Apically 1/3, the root is attached to the alveolus, that amount of periodontal ligament is sufficient for me to start to bring about the extrusion. But of course, the mobility has to be in terms of grade 3, definitely as such. But if it's going to go beyond that, be careful. I'm not saying we won't do it, but be careful because anyway you're going to extract the tooth. There's nothing wrong in trying it. But a simple way is to look at an IOP and say, okay, apical 1/3 is there, because even in the X-ray which Dr. Suhail showed, clearly you can see there's only apical 1/3 of the attachment that is there. Now that should be a ground factor for you to decide whether you want to do orthodontic extrusion or not. non-restorable tooth without sufficient length? Yes, because you can alter the crown root ratio when you do an extrusion for restoration purposes. And of course, if the tooth is ankylosed, we never get to do it, right? So case selection and assessment, orthodontic appliance placement, controlled extrusion phase, that's what I was talking. And this is what is the answer to your question, doc. Stabilization is to 4 to 8 weeks. So normally we follow that protocol just to make sure that we are safe with what we have done. And then an atraumatic extraction, which is extremely important when you're going to place an immediate implant and the immediate implant. And this is what exactly happens, which was shown by Dr. Suhail. You have brackets and archways, which was shown. Now you have clear aligners with attachments. They work in extrusion, which was not happening about 4 to 5 years back. Extrusion was a major issue with aligners. It was pretty difficult to bring about, but nowadays you're able to do it. Some cases, even removable appliances have been used, but not very successfully because it totally relies on the patient compliance to wear it. It's a headache. Removable appliance with a fixed attachment does not work because most of the patients are not compliant with it at all. And then fiber optic and crown lengthening if needed at the end, which is there. These are the procedures that were basically used. We use a bend in the wire or we use this also. But these are all standard procedures which have been used as such, where the brackets have been used for the extrusion. And then your soft tissues, which I'm not going into because he has already showed you exactly where exactly you need orthodontic extrusion is it. Basically, width of the attached gingiva is important in every case, whether it is orthodontia or whether it is implant placement. Width of the attached gingiva is what is required. If you're able to achieve that, it's good. So you look at it where in terms of gingiva, where the attached gingiva is there, if it is connected to the bone, if it is connected to the root surface, then you know that during orthodontic extrusion, an increase in the attachment gingiva will occur. So you look for the attached gingiva. After you take an IOPA, you look at the length of the amount of root into the bone. It's 1/3. I decided to do the extrusion. What will happen to my soft tissue? I go to the soft tissue next. Will the soft tissue also come out? Will I get sufficient amount of attached gingiva, which is extremely important for me to deflect all the maxillary masticatory forces so that my implant is stable in a long run? You look for that and then you come to the conclusion, you look for the attached gingiva. If the attached gingiva is attached to the bone and to the root surface, you can be absolutely sure it is going to come along and you're safe. If it does not, is connected to the roof, during the gingival tissue alone moves coronally if it is not attached. So only the gingival tissue is going to come down, your attached gingiva is not going to come down. And third one is the classification here. This is what I said. I'm not going through this tabular. Do not get intimidated to this table which I'm here. This is what I was stating. There are no hard and fast rules for your orthodontic extrusion protocol. It is totally empirical. It has to be based on your clinical judgment. You have to have the patience to go through it. I showed you this because these are the people who are considered to be pioneers in orthodontic extrusion. And as you can see, they have done so much studies and each one has come. Doc, to answer your question, 6 to 8 months, some have taken 12 months. And then you can see post-orthodontic retention, some have kept it for 6 months.
I see 0.5 monthly and I see 1 monthly.
That's what I said. There are no hard and fast rules. All of them are empirical data based on each one person's study where they have done. You can see that activation is 6 weeks here. This is according to the amount of distance here. This is according to time here. So it varies. Absolutely it varies, totally. And the amount of efficacy of the forced eruption, you can see some people say 100% bone formation.
Because he's slow.
Yeah, 0.5. He says 100%. That's what is the basic advantage there. If you are patient, yes. But this is something which I really do not know because I searched for it because this scares me. 6 millimeters is huge. I just do not know whether they really achieved 6 millimeters of extrusion. But anyway, that's what they have quoted. And what they have done, whether have they placed the implant immediately? Now that is something which has to be answered by Dr. Suhail. I'm not good at it. But all I can tell you is be patient when you get to do the orthodontic extrusion as such. These are such advantages, enhances bone and soft tissue without grafting. So it's a non-invasive procedure. Think about it in your practice as such. Preserves the natural contours.
Dr. Sundar, go back to the clinical that you skipped. Let's see what they have done. Yeah, leave that on for a few seconds. So they are looking at 2-1, is it?
This one.
It's a deciduous tooth. They're trying to, what is it?
This one here as such.
Yeah, it's a deciduous tooth.
No, it was fractured, doc.
Ah, okay.
Actually, this was, sorry, This was a composite that was added.
To make it long.
Yeah. Sorry. Yeah. That's actually not a tooth.
Okay.
Not a tooth. And this was just shown for that particular issue which you had.
When you pull it down,
Yeah.
the gum will.
No, we are also able to do this now.
Ah.
When we have a midline diastema, what we are able to do is now we are able to move it mesially, and as we are moving it mesially, when you are controlling the amount of orthodontic force, trying to keep it to the optimum as much, you are starting to have bone formation there. It's happening there.
And the papilla will follow.
Yeah, exactly.
Thank you.
And here when we have an angular bone defect, of course we brought about an extrusion here, but even when we have an angular defect nowadays, we are able to, and to answer your question about the labial amount of thickness to be achieved, we combine extrusive force of the tooth along with a buccal torque now. That is, we are torquing the root buccally here. So when the root is being torqued, you start to have bone formation there.
But you will not get a thinner buccal bone
Where,
when you are doing that.
yeah, the anterior incisor is always like that, right?
Yeah.
So what we are trying to do is this. We are bringing it down, we are giving the buccal torque here.
This way.
Oh, the root is palatally torqued. Okay, sorry. So when you do that, there's a tension here and bone starts to form here.
Thank you.
Even for an angular defect in the premolar region, it is possible. When we start to tip it and when we start to move it towards the defect, bone starts to form here as such. So this is what it was. And then limitations, that is the first one. It's a time consuming procedure, but I really did not know. It was enlightening to me to sit and hear that even those invasive procedures take about 8 to 12 months. It was quite enlightening. I wasn't very, very aware of it as such. So you can think in terms of orthodontia because that's also going to take the same time. Patient compliance is required. You can convince the patient with aligners and whatever it is nowadays. And then you have, is a valuable unchecked, promotes ideal implant site, combines well with minimally invasive extraction and implant techniques. So that's the theory aspect of it. Okay, rapid extrusions, just in one line. It's basically considered in situations where you find that the patient has come to you with a fractured tooth because of trauma, right? Or you have situations where you have a caries which is subgingival, it's not behaving, whatever restoration you do, the patient is not happy. In those situations, you either do a crown lengthening procedure with gingival. But I'm just going to think in the reverse, flip it. Instead of you doing a crown lengthening procedures, bring the crown down, extrude it. But that's rapid extrusion, where I am not waiting for the tooth to be moved in the vertical direction along with your bone and gum. No, I'm not doing that. I'm just pulling the bone out of the socket. So that's rapid extrusion, where my force is going to be almost to the tune of about 2.5 millimeters. My aim is that you have a wire which is extremely resilient, which has got that amount of energy stored in it. You're locking it in there. So it's going to give you that amount of force there. The tooth is going to come out. But the question to answer that, do the root canal first. Because when you're going to extrude with that amount of force, that artery there is going to get cut.
The second is the natural.
Orthodontic extrusion for the sake of implant site development is slow.
Yes, why?
Yeah? Because you want to bring the bone and the soft tissue along with it. Now you're moving the entire periodontium when you're doing the orthodontic extrusion for the sake of implant site development. So when you want that, physiologically, it is going to take time for your bone and soft tissue to follow the tooth movement.
But doesn't that also happen in the rapid extrusion?
No, I am just pulling it. I am just stretching my periodontal ligament.
Okay, but what is the result of that?
The tooth just comes out.
And what's the use of all of this in orthodontics? To do what?
To pull the tooth out, then I restore the tooth.
Are you going to have bone also coming?
Good question. That's what I said. After we finish the treatment, after I restore the tooth, after I put a crown, whatever it is, I extrude the tooth, rapidly extrude the tooth, pull the root or rather whatever remaining structure of the tooth is from inside the socket. I pull it out completely and then I restore it there. My expectation is it kind of makes sure that the soft tissue and the bone start to adapt to the new position of the tooth, for which stabilization is required. So my assumption is when I put a crown, when I restore the tooth, the occlusal forces are still able to maintain the tooth in the equilibrium zone.
But what about, will it cause the mobility because you have done it rapidly?
Brilliant, ma'am. Many situations so far, practically speaking, we haven't seen that amount of mobility. But theoretically, when you think about it logically, when you extrude a tooth, there is always a possibility that it is going to be mobile, but not to the extent that we thought we might lose a tooth.
So intrusion will go now.
Intrusion duck?
Will not go back.
It does not duck. It does not. These things when we observed, it did not happen. The question you're going to ask me is why? Because logically it should, but no, it does not. So there is something happening there for which we do not have any answer as such. Intrusion is practically impossible. All that claim about all those biomechanics, that conundrum of biomechanics which they have all over the world saying that we achieve perfect intrusion, no. Orthodontia, intrusion, forget it. Just forget it.
We can shift the tooth.
All that is possible, ma'am. Bodily moving it, tipping it, controlled tipping, uncontrolled tipping is all fine. The easiest movement is extrusion.
Sometimes it happens like we have only 2 millimeters. Neither they can give us more for implant, neither they can move. They say like it is very difficult to move the molar from
Distalization of teeth.
Distalization of lower molar, forget it.
Also forget?
Forget it.
mesialization.
Mesialization is possible. Distalization, maximum you can get is 1 millimeter.
What is the rebound for both of them?
It will come back that 1 millimeter.
1 millimeter?
You will distalize it 1 millimeter, it will go back to 0 again. Impossible to distalize lower molar. Upper molars can be distalized. Lowers cannot.
Because of bone quality.
Exactly. Even the lower mesialization of the lower molar is one particular tooth movement which is going to take hell of a lot of time before we finish the treatment for any patient. Lower molar mesialization or distalization is almost next to impossible, and that is the reason why the lower molar is considered to be the tooth for anchor. For anchorage, that is the tooth. That's the tooth which is always used. You can play with all your single rooted tooth in the front. Lower molar, forget it. Just doesn't happen. Thank you, Doctor. Yeah, sure.
Nice, thank you. So now what we are looking here, even though we did what we did during the first phase, which was a ready-made connective tissue graft, we did the extrusion, but still the 2 millimeter of thickness at the buccal area of the gingiva is not there. So now we want to make the labial connective tissue thicker. We have attached gingiva, but we don't have thickness. We have keratinized tissue, but we don't have thick phenotype. So the purpose of this procedure is to have enough thickness on the labial surface of the remaining soft tissue, so we could expect to have even bone formation underneath it. When you have a thick phenotype, automatically and genetically the body can create bone cells under it. At the time of remodeling, the bone will be formed under it. So we thought it's best to receive that papilla in the middle and to best receive the bone thickness is to do a free gingival graft. In the beginning, it's full thickness, but once you enter, becomes partial thickness. And that's why it's very difficult. It has to be partial thickness. Now, remember, the reason why periodontists do successful tissue graft and we do unsuccessful tissue graft is the bed. They respect the bed, where it goes inside. They spend a lot of time creating the bed to receive the free gingival graft. For us, we open the area, we take a connective tissue, we place it there. Sometimes it takes, sometimes it doesn't. For them, mostly it takes because the bed they create is sufficient to provide enough blood supply to accept the donor site And that's what I felt is missing in my free gingival graft when I compare it to periodontists who do free gingival grafts. So to create the atmosphere by which your free gingival graft, connective tissue free gingival graft without epithelium, is the bed. The more you have cells waiting to receive that connective tissue, the better you are. Now, of course, because this is very thin, a lot of care should be taken not to perforate the labial thin tissue. Otherwise, then again, you have a defect in your area. Tunneling technique will not give us the papilla. I want to get back my papilla. I'm not sure if tunneling. See, let's go to this tunneling technique. What we did in the first phase was tunneling technique, and it did its job. What job it did? While we were doing orthodontics, the thick gingiva did not make our existing thin gingiva become against us at the time of implant placement. As you saw, when I placed my implant, I did find enough sufficient soft tissue. But that was tunneling. But to do tunneling at this point of time, I don't think it would have given me the papilla. Now remember, this patient has already done orthodontics, implant placement, till today, and first one soft tissue graft, till today nothing after that. So we tried to the maximum to avoid more surgeries. But we found in the long run, probably this area is going to look more unaesthetic, because I saw the soft tissue was slightly running away. Now, probably to pay attention to the 7 laws of Thomas, you want to repeat them till this graph has been open? Who wants to tell us the 7? You can say one and the next person says the second. You don't have to say all the 7 by yourself. We start with you. The first law, platform switch. Second law, did we do platform switch? Yes. Second law, 5 millimeter from the soft tissue. Third law, 4 to 5, huh? 4 to 5, yeah. Third law, cuff height over the bone. So did we do the cuff height? We did. But did we do that straight part in this case? So we missed one of the 7 points. Yes, probably this area that I was placing the crown, also probably I could have stayed more away from the gingiva. That could be also one contributing factor that the gum went slightly higher. But we still have something very important in the 7 points. V shape of the bone. Here there was no bone cuff, bone circle holding the abutment. There was no tension on the abutment. Sorry? Yeah, but that's not any of the 7 points of Thomas. That's a principle of, that's the principles of bone grafting. Yeah. No, I'm talking about this zero bone loss theory principles. One more point, which we did apply here. Yeah, it's related to biology. We did that. Something which we did apply here. Bone density. The osteotomy was, we did not use internal hex. We used internal cone. Internal hex seems to be against you when it comes to zero bone loss. With internal hex, you might have bone loss. With internal cone, you will not have bone loss. Let's come back to this. So we removed the gingiva palatally, but now we are shaving the epithelium because epithelial cells will definitely not heal when it's embedded inside the soft tissue. Now, what is this is Zucchelli's technique versus what is the other way? Well, the other way is to go all the way and touch the periosteum and remove your gingiva. In this technique, you only go 1 to 1.5 millimeter maximum below the epithelium, or you collect the whole thing and then you shave the epithelium off. So you get 1 millimeter of epithelium, not more. You might say, but I'm inside. I might as well take the whole connective tissue. Why should I limit myself to 1 millimeter depth? Yes, because Zucchelli has shown, even though people used to think the thicker the better, but as you bypass the first millimeter, you are not getting a good quality connective tissue. So basically, the suture is important. We saw from Dr. Rashid on Saturday how stabilizing the suture to the tooth is what keeps the soft tissue in the position you want. So basically, suturing definitely plays a big role in maintaining the position of the soft tissue. I mean, you can do all your procedures right, but if you don't stabilize all your work, there is a good chance you're going to lose it all. The same thing with the 1.5 millimeter of the area that is coming out of the implant. If you don't keep it straight for 1.5 millimeter, you are violating the space that the connective tissue likes to rest. And I think that was one of the reasons why we started having a little bit of tissue loss. This area and this area on the ceramic. This could have been concave. even though for the first maybe 3 months, it could have looked ugly while the patient smiled, but at least on the long run, I think the soft tissue would have matured in a more reasonable position downward versus leaving the soft tissue to basically be lifted up. We should. If the patient is unhappy and comes back, I asked her to come, but she says her work schedule is very difficult now, and her husband was not cooperative. She said, I have not seen my wife for 1.5 years. Will you stop calling her? I said, oh my God. I said, well, I'm trying to help to make it like amazing drawing. Yes, I would prefer to make this concave, not yet ceramic. I'll probably do some kind of acrylic, make it extra concave, this area, too much, like more than necessary. Leave it for 6 weeks, to see the maximum extrusion of the soft tissue, and then go to ceramic to be able to finalize the case. You can see it's not going perfectly. We lost a little bit of connective tissue here, but we got what we wanted in terms of, because the smaller the pieces, the less chance for the body to accept it. So the thicker, the better. But again, back to Zucchini, because it's 1 millimeter, it's very difficult to control. In the olden days, we used to use as thick as possible. Now it's not like that. Now we're going with the 1 millimeter or even less than 1 millimeter. Yeah, the 5 millimeter is there. The 5 millimeter law is there, but the zero bone loss surpasses. Actually, Dennis Tarnow did not talk about connective tissue. He only spoke about distance. If you stay 5 millimeter away from the bone, the papilla will follow. We did stay 5 millimeter for the bone. The papilla did not follow. So what we are doing now is thickening the soft tissue, but we missed that concavity thing, which we have to go back and do it as soon as. According to the theory, if you create a thick phenotype, bone will form underneath it. Now, thick phenotype is 2 millimeter and plus. Can I create 2 millimeter there? I'm not sure. So, at least if I have a 2 millimeter of soft tissue, buccally, I can expect when it matures, it will give us some kind of a support for the papilla. I mean, it looks more aesthetic than a flat line. So we are hoping for the best. If you make a thick phenotype, according to theory, bone will form underneath it. But will it always form? I don't know. According to theory, yes, bone will form underneath a thick phenotype. And this is shown in platform switch, where you do roll your gingiva, make it thick, you come back, you found bone was formed on top of your platform switch implant. What does it mean? How did the bone form? You didn't do bone graft. So the thick phenotype, theoretically also, is a proof that a thick phenotype can create bone underneath. But will in such a delicate spot give us bone? I don't know. I hope so. That's what I'm doing, what we're doing. All right, so we are ending this soft tissue grafting. We still have 20 minutes to. When? The date is there. Last year. We waited 3 months for the. Not yet, but she came for removal of suture, of course, but to come for us to change it to another provisional and continue, she is busy with work and she wanted to focus on her work for some time. She has a new job or something, and her husband preferred if she would just not keep coming. So we are waiting for her to come so we can see the final result. So basically, now at the cervical area, we have 1 millimeter more than before. That's it. That's all we have, which is supposed to be enough for maintaining the bone underneath. And because it is the keratinized outer layer and the attached outer layer is the same, so we have that line. See that papilla in between? We did create that papilla in between. Even though the procedure was long and she is not very happy, but we did create that little bit of tissue. That's what the blanching law, according to theory. What is blanching? Blanching is a pressure of the either connective tissue or junctional epithelium or both, right? If it's junctional epithelium and it's slight, it should disappear after 5 minutes. So it's fine if you put it on and there's little blanching and you come back by the time you finish whatever you're doing. If it's gone, it's fine. If it doesn't go away, that means it's all the way to the connective tissue, which you cannot stretch that much, and you shouldn't. And that will lead to bone remodeling, which you don't want. So if you find blanching not going away within 5 minutes, what does it mean? Remodeling. It means negative remodeling. So you have to remove the crown, remove the ceramic, better to send it to the lab, let them polish it, and then place it. Now, let's close this. Now, regarding the other topics, since we are in orthodontic treatment, the diagnosis for this case, so the orthodontics in this case is interesting. The patient comes with narrow space on the patient's left lower, and the other areas seems to have sufficient amount of mesiodistal space for placing implants. So we did everything by the book, except we didn't pay attention at the time of diagnosis to this area. The patient is philosophical, which means she listens to whatever we say and she does not ask any questions. Let me show you some x-rays. So the patient comes like this, and this tooth is decayed. So 2 implants, extraction implant with maybe a touch of sinus lift, and this was the part that, because of the inability to upright the molar, the surgeon decided to use a small implant or a mini implant. And then, do you want to see the surgery or only the complication due time? We have 15 minutes. I think we should go to the complication because restoration was done, all and good. This is the restoration, and this is the maxillary. But this is the restoration of that yeah. Of course, what you expect the problem to be?
Small implant means how small?
3.25. Yeah, fracture of the implant. So we can see the space was very narrow. And let me go to the radiograph so you can understand. Where are we? Where are we? We are here. So as you can see, there is a small line of crack, and now we are thinking of, okay, what to do? Remove is not the problem. Yes, we have to distalize, but as Dr. Sundar clearly said, it's not easy to, the molar in a hard bone, and it's mandibular, it's not maxillary. So placing an implant behind the molar This is the flipped, huh? When you see this circle, that means flip it in your mind. So placing an implant in the molar was able to upright slightly till we at least can get a normal standard implant. And if we leave it, of course, it's going to go back. So the tooth which is going to be here, it's going just enough to have 7 millimeter. It was, I think, 5 to 7, 2 millimeter. That's all we got. And that's all also, we did not allow this to go back. So the crown, the 7 millimeter crown, was the way to keep. Now this is not a mini implant. It's a standard 4 millimeter or maybe even more. It's a standard implant in a 7 millimeter gap. Anyway, going back to as something Sundar said, which was very Sundar in Hindi, means beautiful. He said there is no fixed rules, okay, that it's 100%. It's all, according to Einstein, it's all relative. So according to this case, we could place an anchor behind the molar, we could get 2 millimeters, we managed. In some cases, we can't, and we just have to manage the existing scenario with what we have. This is something Sundar touched upon, and I just wanted to prove him right. This case came with a fracture on the central incisor all the way, and being 17 at that time, the father told me to extract it and implant. And I said, I'm not going to. She's going to grow taller. Her father is very tall. I said, no, I'm going to wait. So then what we're going to do till she's, she's 17 now, 16 or 17. I would like to wait till she's maximum height, maybe 19, not sooner. So we decided to put a post and core, a root canal, post and core, and use, what did he say, don't? What did Sundar say, don't use? Anybody without coffee? He said something, be aware of something. Removable. And this girl, she didn't want fixed, she didn't want aligners, so she accepted removable. But because removable is something which is 100% related to the patient's compliance, and if the patient is not wearing it, nothing is going to happen. So for this lady, as you see, there was no root canal. We did the root canal, we did the post and core, we give her the removable, and she was not wearing. And every time she comes, nothing is extruding. So finally, with all this technology and all these ideas, finally, ready for the final? All this didn't work. All this hard work. Because we knew it should work. And she was saying, I'm wearing it. And we knew 100% that she is not. It's exactly what he said. So orthodontists know that if the patient in the first 1 month, something is not moving, then they're not wearing. So finally we went to final, then she broke the other one, then again it was extruded, and then when she reached 19, we got 3 millimeter of ferrule effect, and we dropped the idea of implant. So we just made, we did root canal. To do the ortho, to do the extrusion, we did the endo anyway. Just 2 crowns. So in 2 years, we actually had 3 millimeter of ferrule effect, which was enough to give her a nice fixed crowns, so she doesn't have to worry about implant. What's the moral of the story? What do we get from this? Maybe I'll ask Sundar first what we get from this, and then everybody else will. So Sundar, what do you get out of this? This young girl who, first of all, she was not tall as her father, and her father insisted on implant, and then we insisted on something very high tech with no much of expense for the patient, but then it was not moving downward, and then we went to this till the tooth started actually moving downward. So what can you, based on this case, what lesson can you inform the audience? Okay, let's listen from the orthodontist. Except Sundar, any orthodontist in town? Nobody? Only him? Okay. First we listen to an orthodontic scientific point of view, then we will all share our... Yes, my dear.
Among the three dimensions of growth, the first one to finish growth is the transverse dimension. And the next is the sagittal dimension, the back to front. The vertical dimension is the last dimension to finish its growth. And when you talk about, you can just imagine, whenever everybody says, suddenly at 17 or 18, the person started to grow tall. The limbs height is decided. So the vertical dimension is the last dimension to finish its growth. In all of us. All of us, the first is the transverse, second is the back to front, the third is the vertical. So vertical means it is just not associated with the cartilages in your limbs. It is also associated with the bone, because your growth is always what is called a cephalocaudal. It starts with your head, cephalo, and the growth happens towards your caudal, tail. So even in the face, it's divided into three sections. You have the skull, you have the maxilla, and you have the mandible. So the maxilla has still got a vertical growth there, vertical maxilla. Your lip has got a growth there. Everything, hard tissue, soft tissue, everything grows. So whenever you are faced with a situation where you have to make a decision regarding extraction of the anterior teeth and placement of the implant, be careful. The vertical growth will play an effect and totally spoil your aesthetics much later. So the idea of not extracting, allowing to leave the root there helps in the movement of the alveolus along. Because vertical maxillary growth in the maxilla is only associated with the alveolar growth. If you're going to have the root there, your bone is also going to come along with it. Your aesthetics is already established naturally.
Okay, since you're going to give me more 5 minutes than usual, I want to finish two cases, 2.5 minutes each, because it ends the ortho session. Now this lady, the interocclusal space was 3 millimeters. 3 millimeters, we cannot do implant dentistry. So in her case, we did the impossible, which is intrusion. It took us a long time. The lucky part was we are dealing with the maxillary bone. So we could intrude maximum 1.5 millimeter after 6 to 8 months, which was enough, maybe because also the bone was not extremely dense around those teeth. But finally we got enough room to place a normal size crowns, and of course we had to basically take care of the entire dentition in terms of her centric, everything was proper. Once we we regained her vertical dimension, we were actually able to give her a good looking standard size implant. So when he mentioned intrusion only in maxilla and very rare, this is that rare case. How many of this I've done? I crossed around 40,000 cases from 1993 till now. In the 40,000 cases I was involved with, this is the one. Only one case I've been able to be successful in intrusion. One. So just imagine how often you see this. This is the last one I want to send you home with this case. This young man, his name is Abdurrahman. To remember him, the name Abdurrahman happens to be more commonly used in Saudi, but he is from Egypt. Thank you. So just to remember him, he's a cute little boy. So he comes with an implant crown which is not nice looking, and he went to many places, they couldn't help him. The implant crown is shorter than the neighboring teeth. So what we had to do to make it work, we had to make a custom made, try again, custom made, no, custom made, I said try again, not the same sentence. Try again with another sentence. Custom made multi-unit abutment. Normally multi-unit abutment comes from the factory, correct? Nobody makes a custom-made multi-unit abutment. But because this young guy, he received his, wait, he received his implant at age of 8. 8. Can you imagine at age 8 in Egypt? So since then, he keeps going to different places because his teeth is shorter and they don't know what to do with him. So even though this is not logical for me to keep making longer crown every 2 years because it looks like this, but because his lip is covering it, it doesn't show, and he doesn't want to have a short teeth in front of his friends. So every 2-3 years, he grows taller. He comes, and because we made for him what? Custom made multi-unit abutment, we were able now only change the crown on top of, because the reason nobody could help him was because they couldn't go that deep to make an impression. It's angulated. They don't have such a degree. The cement, how they would, nobody could think of the solution for this as a multi-unit. And they don't make multi-units for single tooth. Angulated, they don't make. So instead of saying, okay, they don't make, go somewhere else, he said, I've been to 8 dentists. They don't know what to do. So we had to find a solution. So the moral of the story is, if your patient hasn't, as he said, as Dr. Sundar said, if the patient hasn't reached the maximum vertical growth, this is the harm you're doing to the patient. So once we did it to the right height, he came after 1.5 years. Again, there was shortness. Again, we did it in another crown. So pay attention to this vertical growth. It does look very awful, especially if the patient has a high smile line. It will not be, unless you remove the implant, bone graft, soft tissue graft, re-implant, nothing else can be done. Have a good night, and thank you, Dr. Sundar, and all of you.